Hello, my name is Florence Wong. I'm a hepatologist from the Toronto General Hospital and a professor of medicine from the University of Toronto, Canada. Today I'm going to present to you our paper entitled "The New Consensus Definition for Acute Kidney Injury Accurately Predicts the 30-Day Mortality in Cirrhosis with Infection." I'm presenting this paper on behalf of my colleagues who are members of the North American Consortium for the Study of End-Stage Liver Disease. This consortium consists of 12 liver centers in North America. As you all know, renal dysfunction is a common complication of liver cirrhosis, occurring in approximately 20% of patients admitted into hospital. Traditionally, renal dysfunction is classified as either type 1 or type 2 hepatorenal syndrome when a serum creatinine has reached a level of higher than 1.5 milligrams per deciliter. However, in order to diagnose hepatorenal syndrome, a fairly rigid set of criteria has to be reached, and frequently it means that patients cannot start treatment for their renal dysfunction until fairly late into the course of the illness. Emerging data suggest that smaller changes in serum creatinine before reaching a final reading of more than 1.5 milligrams per deciliter are also clinically significant. Therefore, the International Ascites Club and the Acute Dialysis Quality Initiative propose to define acute renal dysfunction or acute kidney injury, as it is now more commonly known, or AKI for short, as a rise in serum creatinine of more than 3 milligrams per deciliter in less than 48 hours, or a 50% increase in serum creatinine from a stable baseline reading within the previous 6 months. Since infections are common precipitants for AKI in infection, we wanted to determine whether these new definition of AKI could accurately predict the 30-day mortality in cirrhotic patients admitted in the hospital with infection. We recruited 337 patients. These were mostly middle-aged men with an admission MELD score of 20. The most common infection was urinary tract infection, followed by spontaneous bacterial peritonitis, skin infections, and pneumonia. The mean baseline serum creatinine was 1.24 milligrams per deciliter. That is the serum creatinine before the development of the AKI episode. Almost half the patients, or 166 patients, developed AKI. 73 patients came to hospital with their AKI already established, whereas the remaining 93 patients developed the episode of AKI during a hospital stay. Interestingly, 57% of patients only had a small rise in serum creatinine of 0.3 to 0.5 milligrams per deciliter. There was no difference in the types of infection observed in those patients who developed AKI versus those who did not. Significantly, more patients with AKI require admission into intensive care units and require mechanical ventilation. Significantly more patients with AKI developed shock or organ failure. 86 patients had a complete recovery of the AKI episode. 42 patients had a partial recovery, whereas 25 patients did not recover from the AKI episode at all. Overall, the 30-day mortality for the whole cohort of patients with AKI was 34%, compared to 7% that was observed in those patients who did not develop AKI. The 30-day mortality for those patients who did not recover from the episode of AKI was 80%, compared to 40% in those patients who had a partial recovery and 15% in those patients who had a complete recovery. Interestingly, the 30-day mortality in those patients who completely recovered from the episode of AKI was still higher than that observed in the patients who never developed an episode of AKI. Therefore, this study demonstrates that the new definition for AKI can accurately predict the 30-day mortality in patients with cirrhosis admitted in the hospital. Thank you.